Welcome to Pharmacology. This semester we'll be discussing topics related to pharmacology from a provider's perspective, and the first thing we're going to talk about is prescriptive authority. So, what is prescriptive authority? And when you have prescriptive authority, it's the legal right to prescribe drugs to your patients. Full prescriptive authority allows us to have the legal right to prescribe independently and without any limitations. Physicians have full prescriptive authority. And for non-physician providers like advanced practice nurses, nurse practitioners, and even physician assistants, the degree of prescriptive authority will vary, and it varies from state to state. Some advanced clinical practitioners that are not physicians have full prescriptive authority, and some have more restrictions. Now, the limitations are generally tied to what type of oversight by a doctor of medicine or a doctor of osteopathy, so an MD or DO, and what is part of the provider's scope of practice. And you can see here by state some of the different types of authority. In Hawaii, we have independent type practice for scheduled 2 to scheduled 5 drugs. So full practice authority is sometimes interpreted differently for advanced practice registered nurses, or APRNs, and physician assistants, because supervisory requirements vary between our two professions. Now, PAs are required to have an affiliation with a physician in order to practice and to prescribe. And all PAs, including those that are in solo practice, have to establish a relationship with the physician, with a physician that's going to take a more supervisory or collaborative role, someone that they can reach by telephone or other means of telecommunication if there's an issue. And this is out of their physician assistant state laws and regulations agreement. And so if the physician and the PA do not have an arrangement that limits the drugs prescribed, then the law allows the PA to prescribe those drugs. If they do have an agreement, then they'll have some limitations. Now, whether APRNs possess full prescriptive authority depends on our legal right to prescribe without a supervisory or collaborative requirement. And APRNs are educated to practice and prescribe independently without collaboration with or under the supervision of a physician. So now if we're going back to this chart and we go back and look at Hawaii, that's what independent means in the column that says type of practice. So in these situations where state law requires practice in collaboration, like for instance, states like California still have a collaborative agreement, physicians may limit the types of drugs that APRNs can actually prescribe. And so it falls under the state law, and it will place additional restrictions in regard to controlled drugs. So the two components that we're going to look at, and they are independence and without limitations. And these are components of prescriptive authority. So when someone says you have independence in prescriptive authority or independent prescriptive authority, this is when the provider isn't subject to any supervision or collaboration with an MD or a DO. They can prescribe independently. Without limitation means that the provider is not restricted from prescribing certain types of drugs, including controlled drugs, with an exception of Scheduled I drugs, as they're defined as having no current medical use. the case for full prescriptive authority. So, advanced practice providers need to complete rigorous programs of study, which you are doing now, largely in accredited programs, and we need to meet stringent national standards. Now, though there are differences in each program, all of these programs should include common components, such as extensive education focused on assessment, diagnosis, management of any health problem, diagnostic reasoning, critical thinking, and procedural skills that are elevated in didactic and clinical courses. Some states require national examinations, some others do not, but these examinations validate the ability to provide safe and competent care. A license ensures that providers comply with the standards of practice that promote public health and safety. So, thinking about advanced practice nurses, we are prepared to fully implement this role in our profession. When we have limited prescriptive authority, this creates numerous barriers to quality, affordability, accessibility, and patient care. And I gave the example of California earlier. They still work within a collaboration as far as prescriptive authorities for their nurse practitioners, advanced practice RNs. But here in Hawaii, we do not. We are able to practice to the full extent of our degree. So in 2010, the Association of American Medical Colleges commissioned a report projecting the future of the physician workforce. And in this report, it said that from projections from 2013 to 2025, there were several key findings. And it said by 2025, there was going to be a shortage of physicians that ranged between 46,000 and 90,000 plus or minus. In primary care alone, only 12,500 to 31,100 physician shortage was anticipated. Now, as the Affordable Care Act is fully implemented, the demand for provider coverage is going to increase. And these findings are going to echo the circumstances that were reported in 2013. But projecting the supply and demand for primary care practitioners through 2020 concluded that we should fully utilize nurse practitioners and PAs to reduce this physician shortage. And so, to adequately meet the demands of future healthcare needs, APRNs and PAs will need to have a broader practice privilege scope of privileges than some of the states are currently allowing. And this is going to be imperative for those states that still do not have full prescriptive authority. The possession of full prescriptive authority really requires us to think about our responsibilities and to be very mindful about what they are. We have an obligation not only to our profession but to our patients especially. So the main goal is a safe and competent practice while prescribing and managing medications. But this is going to require advanced practice nurses to have sound understanding of what the drugs are, the conditions that we're trying to manage, and it's our overall goal that we do good. So as we unravel the topics for this semester and we continue to think about pharmacology from an advanced practice perspective, we need to really understand the pharmacokinetics and the pharmacodynamics of each drug category. And that is what we will be doing this semester. Which is a good segue into our next topic, rational drug selection and how to do the technical things like writing prescriptions. So as a nurse practitioner, you're going to assume a great responsibility from caring for your patients, starting from a deeper understanding of assessment and critical thinking, diagnosing, management, and now the prescribing of medications, which, although we may be familiar coming from a background training as a registered nurse, working as a registered nurse, it is quite different than just giving a medication versus now having the responsibility to prescribe medications. And sure, there's some similarities and definitely some crossover. And we do need to know, when the best time to give a medication is, what route is the best to provide this medication, what the medication is typically used for, all those things that we did when we were practicing our rights of medication administration as a registered nurse. But now, prescribing medication, we need to think even deeper into that responsibility and what that actually means and what is the prescriptive authority that we have. The best way to keep ourselves and our patients safe is to be very prudent and deliberate in our decision-making process. And there are safeguards that are put in place for that. So we need to maintain patient safety by documenting provider-patient relationship, writing and documenting in our chart clearly that not only do we understand why we are prescribing to our patients, but that the patient understands why we are prescribing what we're prescribing. There are safeguards in place that will suggest that we do not prescribe medications for family, friends, or for ourselves. And you will see some practitioners do that. But remember that these safeguards are in place to keep us, in fact, safe. Finally, we need to document a thorough history and physical exam. We need to include that in the discussion that we're having actively with our patients regarding the side effects, any risk factors, or any other therapeutic options besides the medication. Make sure you have a documented plan regarding the monitoring, titration, if applicable for each drug, and that we're consulting with other providers in the interdisciplinary team whenever there's questions or we are getting a consultation. Make sure that we are documenting that as well. So in terms of drug selection, these are the main factors, and obviously there's going to be other nuances to these factors, but these are the main factors that a practitioner needs to think about. We need to think about the cost of medication. We know that in the US, this cost of meds have indeed risen steeply within the last decade, and the increasing cost is related to multiple factors like corporate competition, not having enough resources. One of the reasons people don't adhere to their medication is because of excessive costs, and you might have seen that in your experience as a registered nurse. Often we're concerned about obtaining the right diagnosis and making our patients, finding what is really wrong with them, that we overlook the key pieces of information that affect whether or not this management or care plan will actually work. And so we need to think about financial status, insurance coverage, and when we can't afford the drug that is prescribed to us, or we can't prescribe a drug that the patient can afford, it's not going to provide us the solution that we or the patient needs. So it's really critical that we ask our patients, if there's difficulty obtaining the medication because of it being too cost prohibitive. Now, if we find that a patient is having difficulty purchasing the actual medications that we prescribe, we can consider changing pharmacies that may have a better price point, or we will have to consider a different drug regimen altogether. And unfortunately, it's not something that we all know, or that there's like a master spreadsheet out there that lets us know. There are some drug costs that vary drastically between different pharmacies, even in the same area. And you need to think about, generics and other programs that will allow our patients to fill their medications within that reasonable cost. So during practice, we'll learn the different healthcare plans or insurances that will allow certain prescriptions and will deny certain prescriptions because of cost and would require us to first choose a lower cost medication. Now, guidelines. Now, these are set by professional organizations, medical and nursing societies. And so, when we're in doubt about what we should do to treat a particular disease or symptom, how we should manage that with medication, we go to the clinical guidelines. And these published guidelines have been reviewed, and they are based on evidence-based practice, and that's how we'll decide on what to do. So for instance, if we have a patient that's diabetic, we're going to look to the American Diabetes Association. A person that may have hypertension, we might look at the guidelines for the American Heart Association or the American College of Cardiology, and so on and so forth. And so following these guidelines is desirable. And we must always take into account that our patients may not fit well into a specific guideline, but that's when we need to use our advanced practice nursing judgment to find a rationale if we're going to deviate from that standard of care. And if you are, you want to make sure that it is well documented and that the reader of your documentation can understand your perspective and your rationale. Also, we need to think about availability. Not every facility that we're prescribing from, or every pharmacy or location, or even if we're thinking about geographical location, they don't all have the same drugs. It really is according to the formulary. And so the formulary is selected by the pharmacists and providers that are within that system. So for instance, the Centers for Medicare and Medicaid Services, or CMS, they have their own formulary. Other insurance companies, private and public insurance companies, may have their own formularies. Certain hospitals have their own formularies. It really depends on the regional and national drug supply, the costs, if there's any available rebates, and if there's presence of generic medications that could be possibly prescribed first. So to sum that part up, the drug that we may want may not be available where the patient is going to pick up their medication or from the facility in which we are prescribing. So we need to become familiar with their formulary. And so once you get your first job, and you start to understand what is within your formulary or the formulary of these pharmacies or healthcare systems, then prescribing is going to be a little bit easier. But until then, just have an open mind, keep on learning, soaking it all up, but also realize that it can change at any time, and it really is driven by cost. Other things that are related to the change of formulary that may not be because of cost is, for instance, if a drug has now been deemed unsafe or there's a new side effect. For instance, omeprazole, we used to just hand that out all the time. We use that to remind you all, we can use that as a treatment for esophagitis or GERD that causes erosive esophagitis. But now, the formularies contain another drug instead called esomeprazole. And so sometimes the drugs just change because they've either refined that drug, or we find that it's causing some type of interaction. And so now let's move on into interaction. So as noted here, this is when, as a provider, we need to also monitor for polypharmacy. Most of our patients, as they get older, I call them oldies but goodies, they will start to be more and more risk for polypharmacy. They're treating multiple disease processes at the same time. We also need to know, is this medication going to interact with food, without food? What are those side effects of other things that they're doing in their life? Their social history needs to be taken into account if they drink. they shouldn't be on certain medications at the same time. If they smoke, they shouldn't be on certain over-the-counter medications. We need to know all these things, including herbal preparations, naturopathic therapies. We need to help our patients understand that over-the-counter medications are also medications and that they need to mention these, because some of the things that we would like to prescribe may have an interaction with these other therapies that they're currently using. Make sure that you document the conversation and that you are providing resources for the patient so that they can understand, but also that you're using the professional resources to check for any interactions when there are multiple medications. And so as the semester moves on, we'll understand like what medications and why, what drug classes and why will synergize with another medication or has a different interaction. Leads nicely into the next topic of side effects, and we all know that every drug has some side effect. There's no drug that has just zero side effects. They may be lesser or greater than others, and sometimes they're not side effects that would warrant you to stop the medication or not prescribe the medication, but merely understand that you should keep an eye on the patient, right? Where you're weighing the risks and the benefits. So one person may experience an adverse effect to a certain medication and another patient won't have any effect at all. But we need to understand what those side effects are. The next thing is allergies. We need to determine, though, before someone puts in the chart and it becomes a little bit more permanent in their medical record, if it is a true allergy. Sometimes it is a reaction that may or may not happen again. And because sometimes things just happen concordantly with taking a medication, and it could have been the medication or it could have been something else. But make sure you do enough interviewing of your patient to understand, is this a true allergy or not? So unfortunately, patients do have allergies to medications of a certain drug class that we really want to use. We know that it's the first line intervention. We know that there's more side effects with the second line intervention. But if there's an allergy, we need to know that so that we can choose appropriately and that it can be documented in the chart, respectively. In the case of severe allergies, such as someone's therapy resulting in an anaphylactic shock or angioedema, swelling of the face, these drugs are absolutely contraindicated. But think about a patient that may have had some vomiting or a little bit of GI upset to a certain medication. You might need that drug again, and you might have to say, hey, this may happen, but the benefit of using this drug is greater than the risk of not using it. Or there's no other therapy that we have right now that's not going to have a similar, type of side effect, but it's not a severe side effect. And talking through that with your patient to let them know. The desired choice would be to use an alternative medication, right? That's just as effective, but sometimes there just isn't an alternate medication. Sometimes there is. Now, for example, a patient that has pyelonephritis or kidney infection, and you're finding that you need to prescribe medication and they're allergic to penicillin. Well, you can't give them that drug class, but maybe you can use a fluoroquinolone instead. But we also know that fluoroquinolones have they have their own side effects. So now, as a provider, it's your responsibility to weigh the risks and the benefits to understand what was this allergy to penicillin, and is this person, is their medical history a contraindication for fluoroquinolone? The last two, we need to understand hepatic renal function. Basically, your drugs are being metabolized either by the liver or the kidney. We need to understand that with this elimination or metabolism, certain drugs can increase their side effect profile because they're not being metabolized or eliminated correctly because there's either liver damage or kidney damage. And so frequently drugs have special decreased doses or different dosing schedules for patients that have known hepatic or renal impairment. And when you're looking through your resources to figure out how to diagnose this patient, you need to know this past medical history is really important because you might have to use this alternate method of prescribing. Let me give you an example. Morphine sulfate is metabolized by the kidneys for the majority. And so if you have a patient with renal impairment, so how would you know? Go look at their creatinine and BUN. And let's say we know that there is renal impairment, then we can still use morphine to treat the pain. However, a better choice might be fentanyl because we don't have to reduce the dose in patients with renal impairment, where if we use morphine, we're going to have to use a reduced dose, and it might not be as effective, and it may still damage the kidney. So just because we're using a different dosing schedule or a lower dose doesn't necessarily mean that we're not impacting that organ. Now, some drugs are safe to give, and some can be used with caution. But it's our responsibility to know what those drugs are and what is contraindicated and what drugs have to be avoided at all costs. Lastly, the need for monitoring. It really is going to depend on the medication, the diagnosis, the treatment plan or duration of the treatment. But some things that or some examples for you to think about when we have drugs that need monitoring, like we can't just give a blood thinner and then not check their levels again. Things like lithium, we have to check their levels. Opioids, any type of immunosuppressive therapies, these things we have to do more continual and continuous follow-up versus other drugs that maybe we can, provide a dose and then check every 3 to 4 months. These drugs that we're talking about here that need frequent monitoring, these are the ones that if they are within their therapeutic range, perfect, great. But if they are outside their therapeutic range, it could actually cause harm. Let's think about a patient that has seizures and we're giving them a anti-seizure medication. If it's not within their therapeutic range, we might put them at risk for more seizures. So knowing and understanding which ones need to be monitored more closely is important. Okay, so what are the key elements to the parts of an actual prescription? We need to have our prescriber name, our license number to practice, and our drug enforcement agency number or our DEA number. And we will get a national number and a local number to the state in which we are practicing. Not every drug requires a DEA number to prescribe, but if it does, or you want to prescribe like opioids, for example, you're going to need a DEA number. You also will need the patient's name and date clearly on the prescription, any allergies, and note that you have checked the allergies, the name of the medication, what the indication is, like why are we giving atenolol? Well, for hypertension. How much atenolol are we giving? And what is the dose and the frequency? So for instance, we want to give 12.5 milligrams of XY medication once a day, but we also have to say how many tablets are we giving and how many should be dispensed and the number of refills. So I might say that, I need to give this medication for this diagnosis. This is the strength in milligrams or milligrams per milliliter or whatever it is. And they need to take it once a day for 30 days. Dispense 30 with no refills. If I want to give a refill, maybe I want to give one, they're going to take it for 30 days. Dispense 60 with one refill. So it really depends on what you think is best and is what is indicated, but it will need all those things, or the prescription cannot be filled. This is an example of a paper prescription, although I would say that most prescriptions that you are writing today will not be in paper form. It will be in electronic form. However, you need to be familiar with what a paper prescription looks like in case there's some technological problems. You're going to be asked to fill out a paper form prescription. There are different ways that we can write a prescription. And I quote, write a prescription. The most common way now is by e-prescribing, and most of the pharmacies have the capabilities to accept some type of electronic prescription. There are some states that actually will not take a prescription unless it is e-prescribed through an electronic medical record. And so with this, it goes directly through the electronic medical record, and it talks to the pharmacy, and they get their prescription in electronic form. So there are some limitations to doing this, because you can't always e-prescribe medications. There are some organizations that don't have a functional EMR. There are some pharmacies that don't have the software capability. So there are some nuances to this e-prescribing. With refills, we can refill either by calling it in. Sometimes our medical assistant or our nurse in the clinic will call in refills, but sometimes it's really easy just to go ahead and e-prescribe and hit that refill button, right? But someone needs to go in and look at the chart, look at the patient's information, and make sure that the refill is appropriate. Now, the other two ways are less common. I'll go with the more common of those two. So you can also telephone in a prescription. It's a very convenient way to call it in. You'll still need the same amount of information that was on the previous slide, but you can just tell the pharmacist or leave a message. But you have to make sure you have all that information. There are some medications that you can't telephone in, like Schedule 2 medications. You can't just call and prescribe or refill these by telephone. And lastly, it's the written version, like telephone or electronic prescriptions. They all have to have the same amount of information. But with written prescriptions, sometimes the barrier to that is that we can't really understand what's being written on. There's a higher chance that there's some miscommunication because of handwriting, not being able to make someone's handwriting out. All could cause, issues. If you work in a place that will still take written prescriptions, or you're writing written prescriptions, you never want to pre-sign any prescriptions. You never want to leave any areas blank and allow other providers or staff to fill those in for you. And you want to make sure that you put your prescription pad in a place that it cannot be tampered with, abused, or misused. All right, and then now lastly, we're going to move into our last 6 slides. They're going to talk about the outcomes of drug therapy that we're hoping for our patients. And so, our medication education, the time we spent with our patients, is going to really influence whether or not our patient is going to get on board with our plan, right? It's going to influence the patient's commitment to carry out their treatment plan. We need to give them the proper medication education. This is not the nurse's job. This is not your MA's job. This is your job as a provider. Now, their job is to reinforce what you've taught them, but it's not their sole job to explain. You as a provider need to explain the importance of the medication, but also you will have to do this in a lot of cases. You'll have to dispel any rumors or misinformation about the medication. You need to address their concerns about possible side effects, cost prohibition. We need to also go back and ask patients if they are complying with the medication, why they're not, if they aren't, or what they are experiencing while they're on the medication. All in all, we have to empower our patients with accurate information and clear guidelines. And sometimes that cannot be done just with one 15-minute clinic visit. We might have to write some of these things down so that they can understand later or have time to learn this information in a way that best fits their learning style. However, we need to, at the very least, provide this education during the visit. It may not be the last time they are exposed to this information, but definitely it needs to be the first time during the visit. So there are some basic components of medical education that we need to address with our patients. The medication name, making sure they understand that there's always going to be two names, generic and the trade name, why they're taking the medication, and what we want to have happen. You're taking this medication because you have hypertension. You may not understand or recognize the difference or see a difference when you're taking it, but there's a desired effect that is happening in the background, right? If you don't let them know that, they think, oh, I don't feel any different than yesterday. I'm just not going to take it. Or I'm giving you the XYZ antibiotic because you have a UTI. By this time in the next 2 days, you should be feeling better. If not, let us know. But they need to understand too when they should start seeing or noticing the desired effect, if they're going to be able to notice the desired effect. Dosing regimen, how much, how often, what time of day they need to take it. What should they do after? Should they lay down? Should they not lay down? Should they be sitting up? Should they not sit up? There are some medications that this is very applicable. And then some medications, it doesn't matter if you lay down or sit up, right? But you have to make sure that they understand that. Same thing with food and other drug interactions. What else to avoid? What else can they not have? And is there a parameter of time? 30 minutes before your first meal, an hour after digesting any meals. How long you plan to have them on this therapy for? Well, you're going to take it for 5 days. If it doesn't help, please extend to 7 days. If it's not working, please give us a call. Or you need to take it for 5 days, but if you start feeling better the first couple days, you still need to finish the length of administration. We also need to let them know what the adverse effects may be, what the risks are, if there's any lab testing or follow-up needed, and if they need to store it in a certain place, like it can't be out in the sun, it needs to be in the refrigerator, it needs to be in a cool, dry place. What do they need to do differently? Can they put their insulin on the counter with their other medications in their drug bin? Or does it need to be refrigerated? These are things that are our responsibility. Now we're going to circle back to written instructions. This has to accompany the verbal education. The best practice for written education is to limit the content, to place the important information on the very top, because for just being human, the further down the information is, the less likely you're able to take it in its entirety, right? We get fatigued by the information and we tend to drift off and not read everything. So whatever you really need them to read, make sure it's up there on the top. You have to write it in an active voice and not a past tense voice. You want to include enough white space in the information so it's just not one big jumbled paragraph together and very difficult to read, but give them time to maybe pace out the information that they are reading. You want to use illustrations that are meaningful to the instructions. And you want to avoid at all costs any professional terminology that the patient doesn't understand, or generally terminology that most patients don't understand. And then you want to check it for readability. Now this is going to depend on our reading level versus another person's reading level. In your textbook, there is a resource that you can find in there. And it's through the CDC.gov/health literacy. It's a PDF that they have created to help you understand as a provider how to do this. And in most cases, you want to keep everything to a 4th and 5th grade reading level so that the majority of people will understand, but not just that, but that it's really at a point where it's attainable and it can be remembered. All right, we're at the home stretch. There's last two things I'm going to talk about is drug monitoring and medication adherence. And so we talked about monitoring a little bit in the last chapter, but you want to think always that there is going to be ongoing monitoring, positive and negative responses to the medication you've prescribed. But we have to think about how often and what type of monitoring is going to produce the outcome. What is necessarily essential to ensure that optimal outcome. There are three main reasons why we need to monitor some drugs is to determine the therapeutic dosage. We need to evaluate the adequacy of our medication regimen, our prescription, and our plan, and to identify any adverse effects. The last thing that's not on here is that I also like to celebrate when it's actually working for the patient. They love to go back and reflect on like, hey, this is actually working. Thank you so much. If you have time to do that, please circle back just to make sure that the patient's outcome is a positive as well. Think about and reflect upon individually what are some drugs that you can actually think about now that require periodic lab monitoring. And I would actually start by keeping record of keeping record in a place where you can easily find some of the drugs that you are working with throughout your education and your experience that require certain monitoring, and so that you have it in a place that you can easily look up as well. And again, as I talked about, I want to talk about adherence. Medication non-adherence costs our healthcare system approximately $290 billion every year, because you directly link that to exacerbation of diseases, being able to avoid hospitalizations if they had just taken their medication, or transitioning to a long-term facility, or even premature death. So medication adherence is really important. Now, this is the extent to which the patient is taking their medication as prescribed. I many times will follow up with my patients and say, how's it going? Is the medication helping? Oh yeah, the medication is great. I do see some improvement, but it hasn't reduced all my symptoms yet, but I have seen some things. So I could take that and just chart, okay, we're seeing some improvement. Or I can ask the next question. Please tell me, how are you taking it? Are you taking it twice a day? Are you taking it on an empty stomach? Remember we talked about this? Oh shoot, I haven't been taking it on an empty stomach. Or like, oh, I forgot. Am I supposed to be taking it twice a day? But I've only been taking it once before bed. So you have to really get more invested and take more time in asking the questions to really understand if your patient is adhering. Sometimes there are things like we talked about cost. Maybe they just don't like the medication, or they forget, or they're taking an alternative dose. Periodically, we need to review the patient's medication therapy regimen, see if it's still working. Keep yourself on top of new drug information, and seeing if there's any new information, resources, research showing that maybe this medication is not the best anymore. Keeping up with the guidelines is also going to help you, because you may need to change it to what is more clinically appropriate at that time. And then other things that we need to evaluate is, are we achieving the desired effect? Do we still need the medication? Can the pharmacy provide this medication? Is there polypharmacological issues, so too many medications or effects? And does this medication create a problem for the patient? Okay, so please take a minute, think about these topics, reflect on this, and we'll see you at the next presentation.